Oh, so this is just so exciting to see more and more FSHD individuals being included in clinical research, which is where we're going to learn more about how to stop this disease. And I'm just going to take a few minutes to tell you a little bit about some of the clinical research and clinic work that we're doing here at UMass. These are just my disclosures. I was the site principal investigator on the Fulcrum trials here that recently concluded. And I also received some grant support from Solve FSHD. This is our Wellstone group and collaborators here that I am just very excited to work with these people. So there are a number of collaborators in my neurology department who also see patients. Some of the other individuals here from Charlie Emerson's group in our basic science group here. Some of you have seen the lab on the 5th floor now. And then we have some other outside collaborators that we work closely with at other institutions. So it's really been exciting to be involved in this group since I think about 2016 for me. So our Wellstone group, one of the things that we've assembled over the years is a large biorepository of muscle biopsies from patients. And in addition, we've got samples either derived from the muscle biopsies or taken separately from skin biopsies or other tissue biopsies that include muscle cells that we can store indefinitely in the freezer and make available to other researchers around the world. And so it's really, it's quite a repository. Some of you are also interested in donating a blood sample today. This is really helpful for some of our ongoing biomarker projects where Charlie's lab is looking for markers in the plasma that could indicate the degree of severity of FSHD and could potentially be used in future clinical trials. So what I want to just briefly cover is a clinical project that I'm really interested in, where we're trying to improve and look a little more broadly at other measurements that we might be able to make when we see a patient in a clinical trial or even in the clinic to get a better sense of how well their disease is being managed or whether they might be responding to a treatment. So I've been very interested in imaging of the muscle. I'm going to show you a few examples of that. I just mentioned about the plasma biomarker study. And then there's some other functional measures where we're actually looking at the muscle activities that are important for everyday life for patients, to link those to, because any treatment that's really going to be approved by the FDA has to show that it actually benefits patients. And so we need better measures of those. And what we are trying to do is compare these measurements that we're making to other established measurements that are going on already in the MOVE trial and some of these other trials. So we're just trying to explore some additional ideas. So here, this is an example of muscle ultrasound. So it's completely non-invasive, just with a little probe placed over the muscle. We can see deep into the tissue. And here's an example where you see at the top, there's a layer of subcutaneous fat, and then there are two different muscles here of the thigh that we're looking at. And then we can even see the bone down below. It's very well demarcated because you notice it's dark beyond that white line, and that's because the sound waves don't penetrate through the bone. So it's very easy to get the landmarks actually. And then this is if the probe is held sort of crosswise on the muscle. So we see that view. We can turn it 90 degrees and we can look at it longitudinally and make measurements of the thickness. And then we can look at the signal because ultrasound's very sensitive. If a muscle is being replaced by fat, we can see that in the quality of the grayscale image. And what we can do is it's very easy to collect about 14 different pictures like this in a short amount of time in the clinic, and then upload them for a radiologist to grade the degree of severity in a blinded fashion. So we can very quickly get some results about how that patient is doing that day and do serial measurements. And so here's an example where patients in our study have come back for 6-month visits, and we're seeing here and there, you see that individual muscles have gone from a level of 1 on this scale. It's called the HECMAT scale. 1 is normal appearing muscle. 2, 3, and 4 are progressively more abnormal muscle with more fatty replacement or other signal changes. And you can see that this has picked up individual muscles that seem to have worsened over those 6-month intervals. And we're obviously interested to see whether this could potentially be used in clinical trials. And what I want to, this is I just want you to look back and not look too closely. It's too much detail on here, but the idea is we're looking for correlations between some of these measurements. And so, for example, right here, this is the average of across all the muscles for that ultrasound reading. And what we see, I want you to just focus on here, is that there's a good correlation between the severity of this measure as it goes higher here for these patients versus controls in blue, and the severity of these 2 different clinical scores that we also use. And also, some of you may have filled out this questionnaire today who are giving blood. This is a patient-reported outcome, and there's a fairly good correlation there between it's an inverse score here, but between normals down here and those who score abnormally on that scale as well. So there's a lot that we're learning just from a simple measurement like ultrasound. And this is not meant to replace more sophisticated measures like MRI of the muscle. But not everyone can get into an MRI scanner. It's not that comfortable. It takes a lot longer, and it's difficult to do in kids or early onset. So, and despite what we might say about how it's tolerable, MRI has its own limitations. And so, but yet we have, we're comparing our patients here to, that we've looked at it with ultrasound to MRI, and we're seeing some really interesting things. So there's a group, there's another Seattle, a Wellstone group in Seattle, and an MRI physicist there, Seth Friedman, who has collaborated with a company called Springbok in Virginia that is using machine learning to process MRI images. When I look at an MRI study, what you see are hundreds of cross sections through the whole body, and it's a little hard to interpret, but they're using machine learning to parse out individual muscles. So these are some of the muscles that I was showing before. This is in the this is in the thigh here in the quadriceps, and here's another one. What you're seeing here is yellow is fatty replacement of the muscle, and blue is more normal muscle. And we're seeing an interesting pattern. About 70% of the time in some of these lower extremity muscles, it's starting at the far end of the muscle with fat replacement and sort of progressively going more anteriorly. And we don't understand the origin of this, but what it's telling us is that we need to look more closely at the physiological differences between one end of the muscle versus another end of the muscle, because this is different from some other diseases like Duchenne muscular dystrophy, where you see fat replacement coming from both ends of the muscle. That's an example of a condition where there's a structural problem in the muscle, and you could imagine maybe the forces are more concentrated at each end, and that's why you get fatty replacement. But that doesn't explain what's going on here. This suggests there's something perhaps related to the physiology or the metabolism of muscle that is different at one end versus another. So these are some of the insights that we're learning from this study. Another type of measurement that we're interested in to look at actual movement and function in patients is to try to get detailed measurements of patients doing various activities. So there's certain well-established measures. One's called sit to stand 5 times. So you basically have a patient sitting, you ask them to stand up, sit down again, stand up, sit down 5 times, and measure the time. And that's all you get is the time at the end of that. But with what we're interested in using cameras to capture some of the joint dynamics and the actual trajectories in space of all the joints and even the forces. And so in a traditional setup, it requires a lot of expensive equipment and markers that have to be placed on a patient and time to set this whole thing up. The data collection's fairly quick, but then there's a laborious sort of manual going through what's captured by the cameras to try to get a sense of the parameters that can then be plugged into models that people who study kinematics have developed over the years. So there are plenty of models if you have the data that can help analyze the joint angles, the forces, even the ground reaction forces based on images that are captured by these cameras. But so there's a group of bioengineers at Stanford that have really improved on this and it's called OpenCap. And it's basically, all it requires are two iPhones or iPads placed on tripods. So you get two views of the subject. And then the subject does not have to be wearing any of these fancy markers, but can just be walking. And it will capture basically the degree of the location of every joint in space during that activity, and then can be processed in the cloud to derive the parameters for this model. So it's a little hard to see unless you see it here. This is my colleague, one of our residents, Eduardo, who participated in this. So we're capturing two views of him. But then what we get back is this model here that we can analyze about over 30 different joint angles and trajectories. So there's what we get at the end of the day is we get something that we can plot, where here's an example of the sit to stand 5 times. And you can see on the top two here, these are controls over on the left at the top. You can see, obviously, they're doing the sit to stand a lot faster than the 4 FSHD patients below. But not only that, there are a lot of very subtleties in the angles of the hip flexion, the knee angle, the lumbar flexion that can be captured by this that we're in the middle of examining more closely. And the other thing that I want to show is that patients with FSHD often have their own mechanisms of compensating. And that might involve, if they're trying to stand up, having to lean to one side or another or do some other movement. And so we're clearly capturing that in, it's the traces in red, where you can see for the controls, there's not much of that leaning back and forth to the side, whereas for the FSHD patients, there was quite a bit more. Now, obviously, not every FSHD patient is going to be able to stand up from a chair without using the arms, but this is just one example of a motion that can be captured and analyzed. We want to look at things like gait and foot drop and weakness of other particular muscles, shoulder function, things like that. And so these models are continuously being improved. And so it's exciting to be collecting some of these and thinking about, what are some of the specific measures we can look at. And so I just want to just point out that we have, I direct our FSHD clinic, so it's great to see a lot of familiar faces here, but if anyone wants to come make an appointment and see us and see our group here or get involved in any of our studies, we have a contact information on our Wellstone website, and Catherine Douthright is here. She's our lead coordinator and organizer of our involvement in clinical trials. And it's going to be really exciting to hear from some of the companies that are here later on today as well. So I think that's about all I want to go through right now. Thank you.